along with more exciting paroxysmal disorders like epilepsy, sleep, neuromuscular disorders. So, before I start, let's have a show of hands. How many in the audience think that it's a right inclusion to put headache out there? And how many of you think it's a chronic problem which doesn't deserve to belong to this place? Can I have a show of hands, please? Who all think it's paroxysmal? Paroxysmal could be different from episodic. Well, we have a 50-50 page which said paroxysmal disorders is the theme of this symposium. I turned over and saw that my name was included in cross-cultural workshop. So to do justice to both parts of this symposium topics, I said let me divide my talk into two divisions. The first part, I'm going to try and justify the inclusion of headache as a paroxysmal disorder which can be confused with epilepsy, sleep disorders, strokes. And in the second part, I'm going to try and appraise, many of you would be aware of this, but we have a number of stalwarts in our foreign faculty who may be keen on knowing how our headaches are different from what they perceive and what they see in the Western world. No talk on headache can be labeled to be current or correct unless we follow the rules as mentioned in the Bible, which is the International Classification of Headache Disorders. And they divide all headaches into three groups: the primary headaches, the secondary headaches, and the cranial neuropathies, out of which, for the paroxysmal part of our talk today, we will be restricting predominantly to the primary headaches. By and large, the secondary headaches are more sustained, so we don't enter into that area. Now, amongst the primary headaches, when I'm going to use the word paroxysmal today, we will largely be referring to migraine and some of the rarer forms of migraine. Why will we not be referring to the trigeminal autonomic cephalgias and so many other primary headaches? That's because migraine is probably the only headache which can present without head pain. So we will be talking a lot about migraine minus the headache. If you look at all the other primary headaches, headache would be the dominant part of the clinical presentation. They follow a pattern which is recognizable. They don't have so much heterogeneity, and they may not have the neurological deficits which might be associated with migraine. So I don't think, other than migraine, the other headaches tend to confuse. They could be repetitive, but then, to me, paroxysmal, when it's included in a theme symposium like this, also I want a little bit of neurological deficit, a little bit of misdiagnosis, a little bit of mimicking, a little bit of confusion, and that only migraine provides all of us. So let's see how we tackle this topic. This is the entire migraine group, 1.0. These are the various subgroups, and out of this, what is the area that we are going to be talking about today? The three areas which are relevant when we talk about paroxysmal headache disorders is migraine with aura. And note the change of terminology here. We used to talk about this as Bickerstaff's basilar migraine. It's now to be called migraine with brainstem aura. This is of 2013, the beta version of the ICSD-3. So therefore, you're now going to be hearing this word, migraine with brainstem aura. And then this is the most interesting part, the hemiplegic migraine. Then you have migraine aura-triggered seizure. There is still an ongoing debate whether the word migralepsy is still the right word to be used for this situation or not. And then you have some episodic syndromes that may be seen with migraine, that may be precursors of migraine, more often seen in children. So these are the areas that we will be focusing on. Now, to understand how migraine comes to be included as a paroxysmal disorder with the other disorders, it's necessary to go back into the evolution of the understanding of the pathophysiology. Till the time of Edward Leaving, it used to be thought a predominantly vascular disorder. And he had a lot of courage when he first propounded his theory of nerve storm in 1873. He described 67 cases. And even today, if somebody finds something new happening in migraine, I think the right way to know whether it's been written about or not is to go back to the book of Edward Leaving and see whether he has described it or not. Amazing. And then William Gowers, in his talk in 1907, when he spoke about the borderland of epilepsy, talked and included migraine along with syncope, epilepsy, sleep disorders. And he used a very catchy term, which I don't think we can really, in so few words, mean so much. Near it, but not of it. That conveys the whole meaning. They are mimics. This was the prevailing thinking at that point of time till Harold Wolff in 1938 swung the pendulum the other way. He, along with John Graham, did some wonderful experiments and spoke about the vascular theory, which continued for a long time. And then you had Liao from Harvard published his paper on cortical spreading depression, Lashley's visual aura. Put together, they proposed that the cortical spreading depression was responsible for the aura. And this was followed by Ollison's studies on cerebral blood flow. Till 1985, they knew that cortical spreading depression was probably the mechanism for the aura, but then how does one account for the pain? And it was left to Moskowitz. Mike Moskowitz in 1984 talked about the trigeminal vascular theory, and he tied up the two and how cortical spreading depression initiated the trigeminal vascular system to induce pain. And today it is now established as a primarily brain disorder and a secondary vascular epiphenomenon, so it's a neurovascular theory. But that still doesn't tell us what is the commonality of including migraine amongst the paroxysmal disorders. 1996, migraine. The first time that a gene, a mutation of which could explain the findings of familial hemiplegic migraine, with migraine-like headaches, hemiplegia, visual defects, dysphagia, coma, a lot of findings. And mutation in the CACNA1A gene on chromosome 19p13 was first seen to be overlapping with other disorders such as epilepsy and episodic ataxia too. And so the penny dropped that although it's a rare monogenic form of migraine, the possibility of migraine being a channelopathy was raised, and then subsequently you had FHM2 coming in. This was a calcium channel, a subunit of the calcium channel, so it was thought that with the influence of calcium, which modulates the cortical spreading depression, and then FHM2 came along on the gene ATP1A2, and then you had FHM3, all of them can give rise to epilepsy. And 50% of FHM patients are belonging to this FHM1 category, and FHM2 is most commonly seen with epilepsy. And so therefore, you had disorders which had near similar phenotype, a near similar genotype, a near similar treatment, but distinctly different disorders. And as of now, we don't have, the common type of migraine is thought to be polygenic, but this is good enough to say that there is a high possibility that it could be a channelopathy. The future will only tell us how we take this along. So therefore, the explanation by which, in summary, I would say that migraine or headache fits into this symposium is that there are ion channels involved, and they give rise to or facilitate cortical spreading depression and brainstem pathways, and through involvement of the trigeminal nerve, which gives rise to pain through the blood vessels, and the blood vessels in turn go on to the cortex and they give rise to pain. So this would be a sort of brief summary for the understanding of how migraine fits in as a paroxysmal disorder. Now, it's the migraine minus the headache which confuses. Now, if you see migraine, it's a phasic disorder. You have a prodrome, you have the aura, you have headache, you have the postdrome. And if you knock the headache out of migraine, it's the surrounds of migraine that confuses as far as today's topic is concerned. It's the migraine aura, typical and atypical. It's the migraine variants. It's the migraine equivalents. And it's the mimics. There are other disorders which look like migraine. For example, the TACs, cluster migraine syndrome and overlap situation. You can have glaucoma looking like migraine, dissection, idiopathic intracranial hypertension, meningitis, giant cell arthritis. So these are mimics of migraine. Then you have the borderlands, the overlaps, MELAS, mitochondrial cytopathies, migralepsy, migraine strokes, CADASIL. CADASIL is a strong suspicion whenever you find migraine-like headaches with strokes and dementia. And then you have what is called the chameleons. When it is migraine, but looks different, epilepsy, vestibular disorders, and functional or psychiatric disorders too. So if you look at all these situations, you can get confused with a simple disorder like migraine, which we are taught to consider whenever a patient presents with hemicranial headache, with nausea, vomiting, photophobia, phonophobia. That is at the level of the general practitioner and the internist. When it comes to a tertiary clinic and you practice as a neurologist, it's the migraine minus headache that you need to recognize. So if we look at migraine with aura, these are the different entities, and important to note is, in the new classification, after 2004, a basilar migraine or migraine with brainstem aura, you are not allowed motor weakness. If there is motor weakness, if a patient has recurrent episodes of vertigo, blindness, ataxia, and has motor weakness, he goes still into hemiplegic migraine. He is not allowed to be labeled basilar or migraine with brainstem aura. This is an important point of note. And when you look at the spectrum, the common typical ones which we all see are visual, sensory, and aphasic auras, but the rarer ones are those involving higher functions. And you find that memory, mood disorders, acute confusional, dysphoric migraine, cognitive problems, and then you have always the need to differentiate between migraine with aura, a seizure, and a transient ischemic attack based on the onset, based on the progression, speed of progression, based on the presence of positive features in seizures. Positive first and negative in migraine with aura, and negative features in TIAs, and the territory involved, and the duration. You try to differentiate between these three entities. And if we thought that migraine with brainstem aura, basilar migraine was an easy diagnosis, it is easy when it is bulleted for you, and when the classification is put together, no motor weakness, and you have any of these, 2 of these 5 features, it looks easy. But I would like you to listen to this story, and can we have the audio, please? He's speaking.
Doesn't know what happens then. And then she goes into deep sleep for she doesn't sleep, she tries to close her eyes, and if she sleeps for a long time, say, even for 10, 12 hours, then she would get up fresh. And then it changed, the whole character changed to headache, vomiting and headache. And when she gets headache, it's so severe, she catches anything tight, and she says, she suffers really very hard, she pants, her limbs are out, just like an epileptic attack. And she would say, Daddy, kill me, Daddy, kill me. I don't want to live, I don't want to live. The attack would be so severe. And suddenly she would conk off. And when she...
Now this young girl this was the father speaking, this young girl had been through so many different investigations, seen so many different specialists, but nobody thought of the diagnosis of basilar migraine. She had loss of consciousness, she had giddiness, she had visual loss, and she was ataxic. So therefore, basilar migraine is a diagnosis. I'm sorry to be still using the wrong word, but then it's out of practice that I am not able to switch so easily. And here is another young man who came with, I'm following the sequence as in the classification. He came with severe headache, and he would get, when the head pain is severe, his left side would feel numb, left hemiparesis, upper limb more than lower limb, left grip would become weak, articulation problem, and he recovered within 24 hours. All his investigations were normal. His workup for a stroke was negative. He did not have a family history of headache. When you see this type of hemiparesis with recurrent, on a background of recurrent headaches, which are migrainous, and where there is a recovery, the diagnosis is sporadic hemiplegic migraine. And if there is a family history, then it would fall into the familial hemiplegic migraine. This can be a very difficult diagnosis to make. We had another patient who was going between epilepsy, whether it was a stroke, whether it was every time she would recover, and whether it was a neuromuscular problem, we were unable to decide, and eventually she responded with anti-migraine drugs, and she was coincidentally taking a trip to Paris, so therefore we sent her along to see some of the famous people in hemiplegic migraine and Ducros, and she came back and said that this is hemiplegic migraine. They also didn't think that the genetic tests were necessary. So therefore this is another diagnosis that can confuse. The connection between migraine and epilepsy can again confuse. You have recurrent episodes of visual aura followed by seizures, and then you listen to this story which will tell you how difficult the diagnosis can be.
Everything started rotating and shaking from left to right in both my eyes, and then after about 1 minute everything subsided, and the left part of my eye it became black, and and after that I don't remember what happened in the sense.
So what do you remember next?
I remember next vomiting, and then I had head pain on my left side of my head. I had severe head pain.
On a scale of 0 to 10, how severe was that headache?
Headache was 8. 45.
So what did your friend tell you was happening to you when you lost consciousness?
He told me that he made me sit on my bed, and as soon as he held me I started getting fits, and my eyes started rotating, and it was red in color, and then I started vomiting, and there was...
So this young man had visual aura, and then he remembers vomiting and headache, and his friend told him that he had fits with the eyeballs rolling and he had tongue bite. So now this type of a scenario, would this be called migralepsy, or would it be an occipital seizure? And migralepsy, the right definition is you need to have migraine with aura, which he did have, and you need to have a seizure for fulfilling the criteria for any type of epileptic attack occurring within 1 hour after a migraine aura. So this patient did fit into the terminology of migralepsy. The other way that the IHS recognizes the relationship between migraine and epilepsy is an inclusion of hemicrania epileptica and the symptomatic co-occurrence of migraine and epilepsy, and certain disorders have more chances of having migraine. And finally, occipital-linked versus migraine visual aura. This is the other area which can confuse, and when it does confuse, we need to remember that the occipital seizures more often are colored, circular, whereas the migraine auras are black and white, and they have this type of a fortification spectrum, and many of the other features are overlapping. So these are the two striking features. There are migraine variants and equivalents when migraine presents in a form other than head pain, and they are less common, less recognized. They can present with confusion, focal neurologic deficits. You get the clue from a family history which is positive, and they are cyclic vomiting syndrome, abdominal migraine, and certain forms are still unrecognized by the IHS, confusional vestibular, cardiac cephalalgia. Cardiac migraine is still unrecognized by the IHS. Some disorders can have migraine-like headaches and confuse, Cadacil, Melas, other genetic vasculopathies. The Handel syndrome, headache associated with lymphocytosis, a monophasic illness which spontaneously recovers after 3 months, and sometimes vasculitis. These are the disorders that you need to keep in mind. Finally, you will find in practice that although I showed you the IHS classification, which has criteria, which is rules to the game, quite often in practice you find that patients do not fit into the textbook rules, and headache criteria are useful as a guideline but not always sacrosanct. Now, coming to the second part of my talk, what are the cross-cultural differences? Now, if you see, based on genes, geography, culture, environment, and lifestyle, there are a lot of differences in regional epidemiology, the literature which comes up from different countries, regions, the clinical presentations, and the barriers to care and the efforts to improve. So, I would even go so far as to say that this region can even qualify to have separate subspecialty of tropical headache medicine. And why do I say that? As far back as 1995, when I came back from after having trained in the US and UK, I first noticed these differences and put together a small paper on differences in migraine prevalence, diagnosis and management, UK, USA and India compared. I took it forward, and then in Lancet we published an article on barriers to headache care in India. And I was pretty happy to see that in 2004 at the European Headache Federation there was a debate between USA and Europe on the American view and the European view. So therefore, there was a concurrence that there are different regions which have different types of headaches. So what is different in India? There are hardly any epidemiological studies which are ratified. The only one probably, but very small in a restricted state and done on 2329 patients, is this publication by Girish Rao's group, where Tim Steiner was also involved, and it looked at primary headaches. Then, when we see the other papers from India, cluster headache is much less in India. Primary headaches associated with sexual activity. Ambar Chakravarti put up this paper where the headaches were different from what is reported from the West. We found that analgesic overuse was seldom recognized, and there is a big role for vitamin D in head pain, probably goes on increasing with latitude. Then we found that there are different patterns of headache. What are the different patterns of headache? We found that hair wash or head bath triggering migraine was an unusual pattern not seen in the West. Ophthalmoplegic migraine, there was a different type of no enhancement following contrast injection in patients with ophthalmoplegic migraine in India. Migraine and cluster headache, there was a number of patients with overlapping features, cluster patients with migrainous features, and the triggers for migraine were unusual in India. Now, if you listen to this story, this is for our guests from abroad to listen to this story.
Is it a bearable or unbearable?
It's an unbearable pain. Sometimes I feel I die of the pain. It's
Do you
so
feel that
unbearable.
light or noise hurts during that time?
Yes, noise hurts me very badly.
And what are the situations when these headaches could be triggered off? Going out in the sun hurts?
Yes, going out in the sun hurts. Head bath hurts. Like having a hair bath, I'm scared of having hair bath. If I have a hair bath, my headache immediately triggers.
Within how much time of a hair bath?
Say around 6 hours, 5-6 hours after the hair bath. If I dry my hair with a hair dryer, then I'll not get a headache. But if I don't, I fail to dry my hair with a hair dryer, I'm sure to get a headache. And that headache lasts for at least 1.5-2 days.
And that headache is the same type as your usual headaches?
Yes, it is very severe throbbing and my head hurts very badly.
So therefore, her trigger was unusual, and hair wash. And she's scared of having a hair wash because 5 to 6 hours after that, and she lives with fear that if she has a bath, then she would get a bad headache. So we published this in Cephalalgia, and we have, at that point of time, we had about 94 patients with a similar story, and you would find this type of story more common in India when you see these headache patients. Not to say that bath headache has not been described from other parts of the world, but then they are talking of hot bath, and this also talks of a bath-related headache, which is with hot water, and this was with normal bathing. Now, this is ophthalmoplegic migraine is thought to be seen only in children, but we are seeing a lot of adults with ophthalmoplegic migraine. Now, the story changed as far as ophthalmoplegic migraine was concerned when this type of enhancement was first reported by Mark et al. Following on this, Jim Lance and Bob Daroff also wrote an editorial on this. They moved it out of the ophthalmoplegic migraine category because they thought it was demyelination. Now, it's moved now from the migraine category. It doesn't belong. The name is still the same. You still call it ophthalmoplegic migraine, but then it doesn't come in that category at all. It's moved to the neuralgia category. And then Now it's called 13.9 recurrent painful ophthalmoplegic neuropathy. So now this terminology in the second classification is dropped. It's called a neuropathy. Now what are we seeing differently? We are not seeing this enhancement in our patients. Here is this paper we published first, suggests revision of nosology based on normal imaging. We had a very small number, 4, and then we wrote about it as a diagnostic dilemma. But Vivek Lal from Chandigarh, 65 patients, no enhancement. So we are seeing a different type, although the clinical presentation is near similar. So enhancement is uncommon in India, and it's seen in children as well as adults. We're seeing a lot of adults with ophthalmoplegic migraine. Then unusual migraine trigger factors. We studied 1,500 patients. We found 26% patients having peculiar Indian triggers. And what are these peculiar Indian triggers? The start point is that chocolate, cheese, and red wine are not triggers in India. You find fasting for religious reasons, application of henna, food triggers, bus travel in Indian conditions, hot humid climate, increased light and noise level, overcrowding, and stress of the education system. I don't know if you would appreciate that children today are put to a tremendous stress when they have to pass out of school. So these are the triggers. Now when it comes to headache care, there are barriers which are different, barriers to care, barriers to treatment, and you find they could be patient related and overpopulation. We find that because of this type of a clinic, we find it's very difficult to take a proper headache history, and literacy levels are low, income levels are low, healthcare systems are different. There are too many diversities within one country. And then you find patients have myths and misconceptions. Headache can be due to so many different reasons, particularly refractive errors is a common notion, and they rush to the ophthalmologist. They delay in seeking treatment because of the fear of drugs. They can't understand migraine when you tell them it's a genetic disorder where you have to continue the treatment for long and control the triggers. The compliance is very poor. If the CT scan is normal, they think it all is normal inside the head, but then migraine always has a normal scan. And when you come to the physicians, their priorities are very different. They have bigger disorders to deal with, so headache goes into the background. And when headache goes into the background, you have misdiagnosis, you have wrong choice of drugs, you have suboptimal dosages given for inadequate durations, you have a faulty attitude of the physician towards a debilitating disorder like migraine, and then patients have fear of side effects, they rely on over-the-counter medicines, they don't know about medication overuse headache, they don't use non-pharmacological treatment. Because of financial reasons, they don't follow up, they have unrealistic expectations, and the joint family system in India, again, a point to note, the grandfather in the house decides which grandson will consult a physician for his recurrent headache, or which granddaughter will consult. So this is very prevalent, and we are now beginning to have the nuclear families, but these are all reasons. You have too many alternative treatments. This is the type of alternative treatment, massage, and Ramdev Baba at his best. Ladies who tie the patta, and much preferable to a consultation with a doctor, and she has a lot of neck pain. Migraine can quite often be a pain in the neck, but this is what she does, and this street side doctor tries to take care of that man's headache, and then people don't know that it does hurt. Now this gentleman, and he calls himself headband Khanna. He's got the prefix of headband because he moves around with a band on his head. He puts in 2 pieces of wood over the temporal vessels. So when it starts throbbing, he puts the piece of wood over there, and that suppresses and that presses against the temporal vessel, reduces his pain. She's an MBA student. Because of the severity of migraine, she has cut her radial vessels because she wanted to commit suicide. She's been hitting her head against the wall. This is branding. And this is a patient who's been taking a doctor, an orthopedic surgeon, who's been taking intravenous pethidine, and these are different ways in which people try to take care of their headaches. So therefore, you will find the other peculiarity is, which I would like the faculty to comment on, we don't see, in spite of the excessive use of ergonomy, we don't see gangrene that often. We don't see it at all. In fact, 15 years of 2 tablets and 3 tablets a day of ergotamine, why don't we see gangrene? I would like my Indian neurology colleagues also to tell me if they encounter this, because it is rampant. Why don't they see gangrene? And so finally, in conclusion, I would say, If you have to compare the East and the West, this is the state of the art which is prevalent in the Western world. We have very simple service-oriented medicine. We do use the International Headache Classification, but then we don't have the sophistication of the clinics. So we did a study and published it in this monogram, Headache Clinics. Approach to headache management. We compared it. This was at this point of time, about 5 years back, and we looked at it. We're not doing too badly though. If you look at the infrastructure and setup, this is excellent, absolutely state of the art. We are lagging behind. It's a plus minus. Level of sophistication is lacking. The appointment system, practically non-existent. Walk-in consultations, 3+. You have to be a good doctor to your headache patient. Record keeping, very poor. Follow-up care, we have a good follow-up care because we are available to our patients 24/7 through the cell phone also, which in the Western world you might not be able to reach your doctor at non-working hours. And the healthcare system is the big problem. Here you have managed care, you can get Botox. Here, you just can't tell a patient to take Botox. He says, if you're going to cure me, I would take Botox. But if I have to take it every 3 months, then I'm not in for Botox. So explaining to the patients is difficult, and the triptans are not available quite often. Now we have about 4 or 5 triptans, but the cost of a triptan drug is so high that patients do not want to take it. And so therefore, we need to, in conclusion, I would like to put this, that you have standard guidelines, but when you are practicing in different regions, a cross-cultural conclusion is that you have to be aware of the attitude, the lay attitude, the doctor's attitude, the burden of the population, literacy levels, financial considerations, what healthcare system prevails in your country, the triggers that are uncontrollable, and you have to modify the guidelines according to that. And I'd like to end my talk with a quiz. Now these are numbers. USA 6, Europe 9, Taiwan 1, Japan 1, Australia 1, Brazil 1. What do these numbers mean? I can give you a clue. This is the clue. Half the world lives here, and this is the composition of the International Headache Society Classification Committee. So what happens in this huge a population, China, India, subcontinent, Africa, South America, practically goes unnoticed when the rules are framed. So we need to modify that situation. Thank you so much.
Thank you very much. That was a wonderful review. Really appreciate the excellence and time you put into that. Obviously, you already asked the one question in regards to the map. I was wondering, many times in the U.S. we find that actually sleep and sleep disruption and poor sleep hygiene actually contributes to migraines and non-paroxysmal headaches. I was wondering if you might address that in your findings here.
Yes, we too do find that most often patients of migraine come and tell us that the moment I wake up, early morning headaches are quite common in migraine, and we look for all the other reasons for ruling out, including sleep apnea, for headaches which come and disrupt sleep or come more on early in the morning. And then finally we attribute it to the circadian changes rather than anything else. But here too we find that sleep disruption is predominantly because of some of the trigeminal autonomic cephalgias, because of migraine, and hypnic headache is the other third cause. And the sleep hours, even when now a lot of people have excessive sleeping hours, they also seem to give rise to headaches. So I don't know if you notice that anything more than 8 to 10 hours does also give rise to headaches. So it's not the less sleep alone, but more sleep too.
Thank you very much. In the interest of time, since we have discussion after our next speaker,
thank you.
I'm going to ask our next speaker to come up if that's possible. Dr. Krishnamurthy is going to talk to us about psychogenic disorders and neurobehavioral syndromes. Thank you.
Good afternoon. I must be a sucker for punishment, because why would I put myself after two such excellent speakers? But here we go. I was thinking about what I was going to say, and then of course I thought about when we say cross-culture, what we are trying to talk about is tropical issues very often. What's so different about the tropics? And of course we're also talking about what's transcultural. And I'm going to just highlight some factors in neuropsychiatry, both the neurobehavioral syndromes and the psychogenic syndromes, which are of interest in the part of the world that we live in. When we say neuropsychiatry, we're looking at obviously the interface between neurological symptoms and signs and psychiatric symptoms and signs. Believe me, there are psychiatric signs as well as symptoms. They're less well documented than neurological signs. So what's tropical about it? The first, that it occurs in the tropics. That's probably what is tropical about it. That it describes neuropsychiatric manifestations of diseases that are more prevalent in the tropics. That's probably true. That neuropsychiatric diseases have unique clinical manifestations in the tropics. Probably true. That neuropsychiatric diseases have unique psychosocial implications. And in one way in which we can think about a lot of what we are talking today is, are there different causes? Are there different manifestations? Are there different consequences for the different disorders that we are thinking about and talking about across cultures? Now, what's specific to tropical countries is it's not just geographical, the tropical zone, or the climate, which is warm and wet. There are socio-economic issues, malnutrition, poverty, overpopulation, these are issues. There are cultural attitudes to neurological and psychiatric disorders, and there are genetic factors. For example, we see true differences in multiple sclerosis prevalence between tropical and temperate regions of the world. Why are neuropsychiatric manifestations important? They increase morbidity and mortality. They certainly have an impact on quality of life. They certainly complicate the treatment of the condition. They certainly do lead to compliance issues, people sticking or adhering to treatment. They certainly make diagnosis more difficult in a number of situations. And of course, they do have many sociological implications. Those of us who work with epilepsy are familiar with the stigma that goes with the condition. Those of us who work with dementia are familiar with the stigma that goes with the behavioral and psychological symptoms of the condition. So in a sense, therefore, there are a number of implications that we ought to be concerned about. So we have both semiology and causation factors, seizures, non-epileptic seizures, affective somatoform symptoms, which we'll talk about briefly, psychotic symptoms, catatonia, delirium. We see all this as syndromes. And of course, we see hysteria, we see somatization. In Southeast Asia, we see running amok, which is a form of episodic discontrol, which we'll talk about. And we do see some interesting acronym syndromes, which are typical to this part of the world, when we start caring for people with various forms of disability, which I'll just talk about as well. One important cause, and I'm quite surprised we've not brought it up yet, because in all Indian meetings it comes up quite early, is what we see as cysticercosis and infectious diseases. And infectious diseases do have fairly unique neuropsychiatric manifestations. And of course, they are more prevalent in the tropics. Here's somebody whose brain is studded with cysticercosis, and psychiatric symptoms can be the manifesting symptom of neurocysticercosis in as many as 65% of neurological outpatients. This is what has been shown. Depression, quasi-psychotic symptoms, not typical of schizophrenia, confusional states, these are quite common manifestations. We've seen our share of patients with cysticercosis here who do present with neuropsychiatric manifestations. And of course, psychiatric morbidity is associated with active infestation. It's associated with intracranial hypertension, And of course, it's associated with pre-morbid history of having had similar symptoms before the infection manifested. Herpes simplex is something that we see quite frequently, and we did discuss a patient this morning where that was considered as one of the differential diagnosis. Patients present with fever and headache, they have generalized tonic-clonic seizures, but they often have confusion, disorientation, and memory deficits with very clear temporal lobe being disproportionately affected, as you can see in the picture, with the very extensive hyperintensities in the bilateral temporal lobes. And of course, in the neuropsychiatric sequelae are a chronic post-infectious state with temporal encephalomalacia, frontotemporal gliosis. People tend to be emotional, irritable, anxious, depressed. They have left prefrontal hypoperfusion, which persists. They do have long-term memory deficits, which are associated with amygdalo-hippocampal atrophy and sclerosis. They continue to have seizures, and of course, they can develop, with the destruction of the bilateral temporal lobes, the lobe-Bucy syndrome, which is a very typical manifestation of bilateral temporal lobe damage. The other thing that we see in abundance are vitamin deficiencies. Most vitamin deficiencies, B1, B3, B6, and B12, all cause neuropsychiatric symptoms. Confusion, irritability, depression. These are symptoms that we see very often with vitamin deficiencies. CMC Vello has reported depression, which is associated with subacute combined degeneration of the seen in the spinal MRI. We do, of course, also have patients who come to us with red herring presentations. There was this cab driver who was brought into clinic one day, and he had just witnessed an accident 24 hours ago. And in the 24 hours that followed, he was found to be confused and disoriented. And in reality, when we examined him, when I examined him, he had bilateral papilledema, and he actually had Japanese B encephalitis that was undiagnosed. It was attributed to his having witnessed an accident. And unfortunately for him, he lived for about 10 days and then succumbed to the illness. So that is one case. We have had a migrant worker who presented with herpes simplex encephalitis, but that was again attributed to the breakup of his marriage, and he did not receive treatment for some time. Luckily for him, he did actually respond well to treatment. Most interesting patient we've had also is a gentleman who had a discussion with a nephew about property, and at the end, that discussion didn't go very well, and the nephew threw the food which they were eating across the room onto the wall behind his uncle. And this incident so upset him that he was found to be confused, disoriented, and suffering from memory loss thereafter. Interestingly, this wasn't a hysterical manifestation. He actually did go on to develop fairly profound dementia. He remained under our care for about 7 years, and he never recovered from that incident. And pre-morbidly, until the day before, he had been going to the bank, he had been dealing with his usual activities, and there was no suspicion of the man being demented at all. So we do see unusual manifestations in this part of the world which are related to and unusual attributions as well. Running amok is something that's been reported widely from Southeast Asia, and various forms of running amok have been talked about. Mengamuk is making a furious and desperate charge. Baramuk is a personal loss and sadness, and its amok follows rage or perceived insult or vendetta. The person often acts irrationally. There is homicidal and suicidal behavior. There may or may not be a previous psychiatric history, but it's thought to be a syndrome of episodic discontrol. DSM-4 calls it a culture-bound syndrome seen in primitive societies, which is rare today. And it's been commented that it's not the running amok itself which is culture bound. It is the way in which the person runs amok, which may be. So the manifestations and the the weapons used and so on are what the culture determines. It could be a feature of depression, psychosis. It could be a feature of a dissociative or a hysterical disorder, and it could be a feature of a personality disorder. Of course, it's a very common medico-legal problem because episodic discontrol often comes up in medico-legal situations. The person says, I have no memory of this, and I was not in control of myself, and therefore I cannot be held responsible for what I did at that time. And that is, of course, a very difficult and contentious argument which one can have till the cows come home. Catatonia, of course, the syndrome of Carl Baum is a syndrome that is seen less commonly now in the West. It still remains reasonably common in the tropics. What I'd like to point out is that the causes of catatonia are very much more medical than psychiatric. There is a belief that depression and psychosis causes catatonia. The smaller proportion of catatonia is caused by depression and psychosis. Infections, metabolic syndromes, all of these can cause catatonia, and since we have a high prevalence of those in the tropics, we do tend to see those causes. We've seen typhoid causing catatonia, for example, and we've seen a number of other infections and metabolic conditions cause catatonia, including Japanese bee, tuberculous meningitis, cerebral malaria, and a host of other syndromes. Another thing which was described in the West in the previous, not in the last century, the century before last, was group hysteria. It continues to be reported in non-Western cultures, and when two or more healthy people start to share similar beliefs and symptoms. It often happens in school children, it often happens in co-workers. It's usually a mass response to some kind of concern or fear that people develop. In India, we do see this as part of religious rituals, and you can see various manifestations of it. For example, in temples, there are people who have very similar symptoms, all manifesting together. And of course, reports like this, which talks about a large number of school children having developed group hysteria, still tend to keep coming out in non-Western cultures. Just to very briefly allude to the spectrum of non-organic neurology, you have hysterical syndromes and somatoform syndromes at one end of the spectrum. Here the idea is that there is no conscious awareness of what is happening. The person is not aware that they are manifesting a symptom for a psychogenic reason. On the other hand, there are what we call factitious disorder symptoms, and factitious disorder is the condition where the person is addicted to the hospital environment, is very much more comfortable in the hospital environment, and tends to repeatedly seek consultations and reassurance and manifest with different symptoms. One famous story related to factitious disorder is that of the Munchausen syndrome, the Baron von Munchausen story. And then, of course, there is overt malingering, which is for gain. The person knows that they are putting on the symptoms and they have a very specific purpose in doing so, like avoiding going to court or avoiding being in prison and things like that. So all three are manifestations of non-organic neurological states. Now, there was a very famous paper by Elliot Slater which reviewed the diagnosis of hysteria at Queen Square, the mecca of neurology. And 10 years on, when he looked at a lot of people who had been diagnosed as having hysteria, he found that the diagnosis was wrong 90% of the time. And this paper really put the fear of God into a lot of people, because it meant that even very eminent neurologists were turning away patients as hysterical, when in fact they went on to develop an organic cause which explained their symptoms. The paper was revisited about 10 years ago, once again in the National Hospital, and mercifully what they did find was with modern technology, the misdiagnosis of hysteria came down to 10%. So we were getting it right very much more often now than we were getting it right previously. And of course, people therefore can have organic causes that are undetected, manifesting as hysteria. We heard the very good examples of migraine, for example, where there are manifestations which could be thought about as completely psychogenic. There are psychiatric disorders like depression, which present with physical symptoms, abnormal illness behavior, the preference for the sick role that we talked about, Munchausen, and of course, overt gain or malingering. What we see here are also unique cultural attributions to illness. So we have this 45-year-old university graduate, fairly well-educated person, working for a multinational company, drawing a decent income, living in Chennai, and he had a very peculiar symptom. He would climb the steps to the railway station where he lived, and as he reached the top step, he would become breathless, he would collapse briefly, and he would have jerks of his limbs. So he was thought to have possibly seizures, he was thought to have some kind of a cardiorespiratory syndrome. He was widely investigated before he came to us. When he came to us, we spent a lot of time talking to him. And what we found was that he had multiple autonomic symptoms which seemed to be triggered off by this act of climbing the stairs. And when we went deeper into this, we found that he had lived in the same area for a very long period of time, had become prosperous and built a 3-story house, which was much more than most of his relatives and friends and neighbors had achieved. And he had been told that black magic is being practiced on you because people are very upset by your success. And these thoughts would preoccupy him, especially when he left his home and went to work every morning. And basically, with management of anxiety, with cognitive behavior therapy, with rationalizing those thoughts, he actually managed to get over these symptoms. And he did not have any decompensation, either cardiac or respiratory, that would explain the symptoms, nor did he have seizures or any variant of seizures. So cultural attributions to symptoms are something, or cultural causes are obviously very important when we start talking about psychogenic syndromes. This is another person I've presented frequently. I've shown this video, and we're still looking for advice here because we haven't really identified what it is that the person has. But this is a 20-year-old girl in her second year of university. She was living at home with her mother. Her father had deserted the family, and they were in strained financial circumstances. She was diagnosed to have epilepsy in adolescence. She had a history of staring episodes and generalized seizures, which were reasonably well controlled. She came to hospital with a 6-month history of significant worsening of seizures. Frequent generalization was described, and by the time she came to us, she had gone on to polypharmacy with little effect. There was no improvement in her seizure control. When we went into the history, we found that her sister had got married, and for dowry reasons was sent back to her parental home, and she actually had committed suicide. And this young lady had left her sister at home alone, gone to college, and when she came back, she was the first person to see her sister hanging from the ceiling fan. So it's a fairly traumatic, extremely upsetting experience that she had had, and her worsening of symptoms coincided with that experience. Now, we would probably think of it as a standard, seizure episode, but I'm going to try and get this video going.
Yeah.
This was the day before we had video EEG. So she's having a video taken and an 8-channel EEG running side by side. So she had these movements of her feet, and then she had these very unusual movements of the face.
ரொம்ப டென்ஷன் எமோஷனலாக உண்டு
which we think are very hard to mimic.
கைக்கே வச்சுக்கோமா மருந்து தான் நான் சொன்னா தானே போட்டுக்கிறேன். உன் பேர் சொல்லி பார்க்கலாம். என்னெல்லாம் மருந்து போட்டுக்கிற தெரியுமா? என்னெல்லாம் சொல்லு.
So she starts talking, and the movements which appear to be terribly involuntary stop. And I'd like an opinion from our experts as to what these movements may be.
Wow, I agree. It looks like it would be very difficult to do voluntarily. One question, on repeated episodes, would she break with speech? Or, because it looked like there, I didn't quite understand what was being said to her. It sounded like there was a delay, and then she was able to start.
So she has this cluster of involuntary movements, which, I mean, the best description I've heard is myokymia. And then she's asked a question, what drugs are you taking for your epilepsy? And then she starts naming the drugs. And when she starts naming the drugs, she stops having the involuntary movement. And there was a delay in starting to name the drug, but I don't think it was because she was confused or disoriented. It is more because, and of course she had those movements of her feet as well, simultaneously.
I think the foot movement looks more voluntary, potentially. It doesn't look as quick. The interesting thing, when we get to her lips, it looks like to me, and appreciate your thought, it looks like there's a very rapid component to this that's almost arrhythmic. And I don't know.
That's a good orofacial movement. I'm not sure I can duplicate it, but it strikes me as very unusual for any kind of automatism, for example, or repetitive focal seizure activity involving her orofacial musculature. So, you'd like to know what her EG showed during this and so on. My suspicion would be that this is not epileptic or physically based.
So the EEG, which was running side by side, was completely normal right through this episode. There's no change on EEG at all. She had a good alpha rhythm right through. And without too much of drug change, actually by treating her for her psychogenic causes, we got her a lot better. And we concluded, therefore, that the worsening of seizures was probably a mixture of both non-epileptic and epileptic seizures, with the epileptic seizures remaining fairly well controlled, but the non-epileptic seizures being very profound given the circumstances. But once again, the cultural causation is what I wanted to highlight, a profound psychological event in the family resulting in a breakdown of seizure control. This has been talked about. There is much talk about somatization in non-Western cultures, and somatization and somatic attribution is having physical symptoms with actual psychological or psychogenic causes. And there have been a number of studies which have shown that people from non-Western cultures, for example, Indian and South Asian people living in Great Britain, tend to manifest physical symptoms more rather than psychological symptoms. And they tend to amplify their symptoms, and they tend to attribute to these symptoms. So rather than say that I'm depressed, I say that I'm feeling tired, I have pain. So there's amplification of the symptoms, and then there is attribution of the symptoms. And this is something that we see a lot of in our practice. In fact, if one works in a large public hospital in India, and certainly this part of India in Tamil Nadu, we talk about the KKK syndrome, which is the Kai Kal Kodachal syndrome, which means that the person comes and tells you that, oh, my Kai Kal Elam Kodaidu, which means my hands and legs are all aching. And that is a very typical presentation of somatization in our culture. The other thing that attribution to black magic, spirits, role of native and faith healers, these are very common in these in non-Western cultures. And what is also interesting is that these patients have been found to acquire psychological models as they go through the care process. So they come believing that this is all somatic, with somatic amplification and somatic attribution. But as they go through therapy, they actually discover the psychological causation to these symptoms. So this is what the man who collapsed on the steps said, that I've been quite successful. I built a 3-story house. My relatives are jealous of me, and I think that they may have cast an evil eye or performed some black magic, which is why I'm collapsing and having these episodes. So I've talked about somatization and somatic attribution. In managing neuropsychiatric disorders, we see some interesting acronyms. So one is the Parents in India, Children Abroad syndrome. I had a call from an Indian origin oncologist, very eminent person working in the US and living in the US. And he called me one day to say, some years ago, to say, can you go to my parents' home and see my mother? I think she's developing dementia and I'm very concerned about her. And he said, oh, they live in a garden flat. I've got 3 people looking after them round the clock, and it's all hunky-dory, but she's losing her memory. And when I went there, sadly, I could smell the urine from the front gate. So that was the level of care that these 3 people who were being paid to care for were delivering. There was no family member to provide a coherent history or give us a proper sort of chart of what medications these people were on or what the problems were. The lady was nearly 90 years old and was in moderate dementia. The husband was 95 and completely blind. Now, this is not an unusual Indian story today. We have many patients where the parents are here, they live in splendid isolation, they actually have a lot of money coming to them from the children who are working abroad and living abroad, but there is no one to actually provide care. And so hence the emphasis on the pica syndrome. We see the opposite with young children with attention deficit hyperactivity or various neurodevelopmental disabilities, where there is no parental attention to them when, for most part of the day, because both parents are at work, they're usually under the care of the maid, and there is no one paying attention to them. So the child at home, parents at work is something that we see a lot of as well. And because of the lack of social support systems very often, the implications of having illness are very, very different, therefore, in our culture. Just to quote the Mental Wealth of Nations paper, which was published in Nature in 2008, and where it said that countries must learn to capitalize on their citizens' cognitive resources if they are to prosper both economically and socially, and that early interventions for emotional health and cognition will be the key to prosperity. And this is probably quite true, both when we look at the children with developmental disability and when we look at older people who are beginning to lose their cognitive abilities early on in life and are not able to take care of themselves. And there is a need for cross-cultural focus. So we work here with a team approach. We have many members of the team taking part in the patient's care, and we believe that a multidisciplinary model of care is what will work for the vast majority of these more complex syndromes. And this is our typical workflow. A patient reports to the clinic, they are triaged by the physician, they are seen by the whole team. The physician then reviews the reports, also the lab reports and imaging reports, and then a treatment plan is put in place. And we believe that continuous counseling and advocacy are something that patients with a vast majority of neurological conditions and mental health conditions need. For example, many people don't know what disability entitlements that they should be getting. Many people have no idea how they should be seeking appropriate care or benefits. And if the healthcare system can't give them that information, they are never going to get it. So that is something that we feel is very, very important. So in terms of causes, therefore, we do have unique infectious, inflammatory, and psychosocial causation for symptoms. And I thought we should highlight that. In terms of manifestations, we do see very atypical manifestations. Amok, for example, is a good example of a culture-bound syndrome that may have biological causation, which has never been properly investigated. And then, of course, in terms of consequences, the consequences that we see of illness in this culture are very different from what is seen in Western cultures. And they too need focus, because in terms of public health, a public health vision, I think being able to prevent causation, but also being able to tackle the consequences is both very, very important in terms of being able to prevent disability. And I think that's one of the reasons why a cross-cultural dialogue or discussion is actually necessary. So there is a rich interface between both neurology and psychiatry in the Tropics. There is it is an important cause of misdiagnosis, inappropriate treatment, and of long-term disability. A lot of the work that we do is poorly documented and poorly published, and I think we have no one to blame but ourselves, because we get so preoccupied with looking after patients that we are not able to or willing to, in a number of instances, put down what we are seeing. There is a unique opportunity for Indian scientists to lead on, and we do have an interdisciplinary PhD program in VHS. Dr. Subbulakshmi, we're very happy to talk to people about that if people are interested. This was our first book on cross-cultural issues in dementia, and I'm very happy that the next one is on epilepsy, and it's about 90% complete, so we hope to see it come out this year. Thank you so much.
That was wonderful. Thank you very much. Are there any questions? I was wondering, in the U.S., we actually have a fair number of evangelists who are making the practice of faith healing. And in fact, it's interesting, if you ever watch on TV these faith healing events, they actually look very similar to non-epileptic or psychogenic events. Just not sure, are there similar types of I know we've seen a film earlier regarding a movement disorder, but I was wondering if you could speak about that in regards to your experience.
There is a number of situations where we do see psychogenic events take place. There are, for example, temples in some southern states, like for example Karnataka and in Kerala, where it's well reported that there is both individual and group psychogenic type of events and activity that takes place and is manifested during particular festivals. A number of temples actually have a person on call who is able to invoke the god or goddess into him on demand. And that is very often very interesting to see. So that's just a part of the culture, and that by itself is not considered a problem. In fact, that person would be considered extremely fortunate or a slightly better person in that social milieu. So we do see various manifestations of hysteria, and we do have our own version of evangelists as well. And they actually exist across cultures, across religions as well. Dr. Mishra.
I just wanted to comment about psychogenic non-epileptic seizures. We see them in large numbers. Some people don't want to provoke them. use certain tests, like saline injection or patch test or whatever. What is your take on it? Should we do it? Should we not do it? Is it, some people say it is unethical to do these tests and you are taking to deception by giving a placebo. What do you think?
I think the widely prevalent view is that at best one could perhaps use strong suggestion as a way of trying to see if a seizure would manifest itself. But anything more than that, people are very skeptical about, especially the use of a sham treatment as a way of bringing out the non-epileptic seizure. What we also see with our patients very often is that, and I'm sure, sir, you probably have the same experience, that you don't often, beyond the point you're not too confused about whether it's psychogenic or not. We are able to make up our minds that there is a psychogenic component to this. So we then find that when we offer them the multidisciplinary care and they have the opportunity to spend time with a counselor or a psychologist, we are able to unravel what may lie beneath the psychogenic seizure. And very often it resolves itself better as they go through the care process. So we prefer that approach actually, rather than pushing on the diagnostic part.
To further up follow up with that question, in the U.S., in westernized areas, we find a high incidence of anxiety or depression associated with psychogenic events, and in fact, I think there's some growing evidence that we need to also treat that in the culture here. Is that a similar finding, or is that something that's not connected?
It's a very good question, because in many instances here we find more somatization. So with the same person, if you say to them that, do you have anything wrong with your head? They'll say, oh yeah, I've got headache. And if you say you have anything wrong with the chest, then they say that, oh, I have palpitations, I'm breathless, I can't walk, I have irritable bowels, and so on. So in a sense, rather than reporting that I'm feeling sad or I'm feeling anxious or I'm feeling panicky, they tend to report a number of physical symptoms, additional physical symptoms. And this is something that is, I think, quite unique to our culture. What's been commented upon also is that many native languages actually don't have words to express emotions appropriately. To give you an example, the language of this state, Tamil, it does not have a single word that encapsulates depression correctly. So we talk about mana alutham, or pressure in the mind, or we talk about mana ulaichal, which is virtually a swinging or a wavering mind. But we don't actually have a word that encapsulates depression. And similarly, we don't have words for orgasm, we don't have words for a number of other human experiences. And so that limitation of language may be partly responsible for people preferring to manifest with physical symptoms as opposed to psychological experiences as in these psychogenic states. So.
Thank you. Are there any other questions? Yes.
In lighter vein, I just wanted to share something to end the evening. Actually, this Malaysian thing of Mangadok and Berdak and Amok, when they go Amok, if they are wearing their national costume, they always carry a little dagger called Krish. So I just wanted to give that allegory when they are in the villages, if they are running Amok, they brandish this and they run amok with that weapon. So it's just a little light vein to share.
Thank you. Thank you.
Well, thank you very much. Thank you. All right. In the interest of time, we're going to continue on with our next speaker, Dr. Matthew Alexander, who's going to talk about the clinical approach to paroxysmal neurological disorders in India.